Hello and welcome to this talk. My name is Dinesh, and today I'm going to be talking about a model-free approach to automatic dose guidance where we use a recursive least square based extremum seeking control to compute the optimal insulin dose for patients with type 2 diabetes. Insulin is an important hormone secreted by the beta cells in the pancreas and plays a vital role in blood glucose regulation. High level of blood glucose stimulates insulin production, which signals the conversion of glucose to glycogen in the liver, as well as the absorption of glucose in the cells, thus bringing the blood glucose to a normal range. Improper functioning of this blood glucose regulation results in diabetes, which is a metabolic disorder characterized by high blood glucose concentration. Diabetes is classified into two types, namely type 1 diabetes, which is due to the absolute lack of insulin production by the pancreatic beta cells, and type 2 diabetes, which occurs due to an imbalance between insulin secretion and insulin resistance, leading to elevated blood glucose concentrations over prolonged periods of time. The absolute lack of insulin production in type 1 diabetes requires lifelong insulin replacement therapy, example using an artificial pancreas. Artificial pancreas uses a continuous glucose monitor and an insulin pump for glycemic regulation. Now, treatment of type 1 diabetes using artificial pancreas is a well-studied problem by control engineers, and majority of artificial pancreas is based on different variants of model predictive control. Type 2 diabetes, on the other hand, is caused mainly due to insulin resistance. And the standard treatment procedure for type 2 diabetes is commenced with changes to lifestyle such as diet and physical activity, and this may be accompanied by the use of non-insulin pharmaceuticals such as metformin to improve the insulin sensitivity. However, if this is not sufficient to bring the blood glucose within desired targets, then insulin treatment is commenced, which involves manually administering a dose of long-acting insulin, which is also known as basal insulin or background insulin, once a day at fasting conditions. Despite the fact that type 2 diabetes accounts for around 90% of all the cases, relatively little attention has been provided to type 2 diabetes by the control engineers. This is mainly because type 2 diabetes is a challenging control problem. Type 2 diabetes is a relatively more heterogeneous disorder than type 1 diabetes, since type 2 diabetes patients may experience different levels of insulin resistance from one patient to the other. And also, the insulin resistance also changes within the same patient with age, duration of diabetes, diet, physical activity, etc. Furthermore, the actuators and sensors for glycemic regulation are fundamentally different between type 1 and type 2 diabetes. This is because in type 2 diabetes, the insulin is injected using a insulin pen based on a self-measured blood glucose measurement once a day taken at fasting conditions. As such, the heterogeneous nature of type 2 diabetes, as well as the actuator and sensing limitations, makes it a relatively more challenging modeling and control problem. Finding a patient's optimal insulin dosage is known as insulin titration, and this is very important because too low insulin may fail to lower the blood glucose concentration sufficiently, causing what is known as hyperglycemia, which can lead to long-term diabetic complications. On the other hand, too high insulin dosage leads to a severe short-term effect known as hypoglycemia. The clinical standard of care approach to an insulin titration involves adjusting the insulin dosage by a few units based on the self-measured blood glucose measurements. However, in practice, the standard titration procedure is seldom followed, mainly because the patients often do not feel comfortable to adjust the dosage without the advice of a healthcare professional. As such, the patient takes a constant insulin every day and records the fasting blood glucose measurement. And during routine healthcare checkups, the healthcare personnel updates the dosage. From a control system's perspective, the insulin titration procedure can be seen as a feedback control problem where the insulin dosage can be determined using integral action. Therefore, the main aim of this work is to develop a model-free decision support tool for personalized automatic dose guidance. That is, we want to automatically find the basal insulin dosage in a model-free way using only the daily fasting blood glucose measurements. And we also want to automatically adjust the dosage to both intra-patient variations as well as to intra-patient variations such that we can have a broad applicability to a wide population. The model-free insulin titration algorithm is especially advantageous given the heterogeneous nature of type 2 diabetes. The proposed approach is based on extremum seeking control, where we define some kind of an objective function. And when the input changes by a small amount, we observe how the cost changes, and we use this information to estimate the gradient from the cost to the input and use this to update our input. And in this work, we define a glycemic penalty function to steer the blood glucose concentration to a target of 5 millimoles per liter. The first term penalizes the deviation from the target of 5 millimoles per liter, and the second term mimics a soft constraint on the glucose level with a low limit of 5 millimoles per liter. And this is added to highly discourage low blood glucose concentration, since this leads to hypoglycemia, which is highly undesirable. The fasting blood glucose measurement can be assumed to be the steady-state blood glucose concentration as a function of the insulin dosage, and thus the penalty function corresponds to the steady-state cost measurement. We can then use extremum seeking control to estimate the steady-state gradient of this static map, which is then driven to zero using integral action. The fasting blood glucose measurement obtained on the kth day and the insulin dosage administered the previous day is used to fit a local linear static function of this form. And when a new observation is available on the kth day, the gradient of the static map can be estimated online using recursive least squares algorithm. Once the gradient of the static map is estimated, we can then use gradient descent to update the insulin dosage. So each morning, the patient records the blood glucose at fasting conditions, and using this, we get the glycemic penalty index, which gives us the static map. We can then use recursive least squares estimation to compute the gradient of this static map, and once the gradient is estimated, we can use it to update the insulin dosage. In order to test this algorithm, we use a virtual patient model, which is a 4-compartment physiological model based on the Medtronic virtual patient, which has been modified for type 2 diabetes. The pharmacokinetic compartments of the model describes how the drug is absorbed by the body, and the pharmacodynamic compartments of the model tells us how the drug affects the body. The virtual patient model is described by a stochastic differential equation to capture the day-to-day glucose variations, and the stochastic differential equation is solved numerically using the Euler-Maruyama method. Note that this model is used only to simulate the virtual patients, and no knowledge of the model is used in the titration algorithm. We now test the proposed extremum seeking approach, which is now benchmarked with the standard of care algorithms, which are simple lookup tables that either increases or decreases the insulin dosage by a few units based on the absolute value of the blood glucose measurements. The top subplot shows the self-measured blood glucose measurement, and the bottom subplot shows the insulin dosage. And starting at 10 units of insulin, the proposed approach shown in these red cross is able to successfully bring the blood glucose concentration to the target zone within approximately 10 days from the start of insulin titration. Whereas the standard of care approaches takes longer to converge to the target zone, with the stepwise approach taking around approximately 40 days, whereas the 202 approach taking more than 2 months to converge to the target zone. We then simulate a case for the same virtual patient as before, where now the insulin sensitivity increases on day 60 by about 30%. Now, the increased insulin sensitivity would require a reduced insulin dosage in order to avoid hypoglycemic events. And we see that on day 60, when the insulin sensitivity increases, the proposed approach promptly reduces the insulin dosage to avoid any hypoglycemic events and keep the blood glucose measurements at the target zone of 5 millimoles per liter. However, the standard of care approaches are a little bit more sluggish, and this leads to several blood glucose measurements below 4 millimoles per liter, leading to hypoglycemic events. The insulin titration relies on the self-measured blood glucose data, which is sampled manually by the patient every morning at fasting conditions. The human in the loop makes this a cyber-physical human system, and we would like to test the algorithm due to human errors. For example, it may happen that the patient forgets to measure the fasting blood glucose concentration on some days, and usually also forgets to inject the insulin dosage on the same day. In order to test the proposed algorithm in the case of such non-adherence to treatment regimen, we simulate a case where the patient forgets to record the blood glucose measurement and inject insulin on some days chosen randomly, shown by these gray bars. And we see that the proposed algorithm is able to bring the blood glucose concentration to the target zone despite non-adherence to treatment regimen. Now, one of the main advantages of using a model-free insulin titration method is that it does not require adapting the models to individual patients. This would enable wide applicability of the proposed algorithm on a wide population of patients. Now, in order to test this, we consider a population of 50 virtual patients, each with different levels of insulin sensitivity, endogenous glucose production rates, and insulin production rates. And we use the same algorithm with identical controller tuning parameters for all the 50 patients. And from this plot, we can see that the self-measured blood glucose for all the 50 patients are successfully brought to the target zone within around 2 weeks from the start of insulin titration. The histogram shows that 75.45% of the SMBG measurements recorded in all the 50 patients were within the target range of between 4 and 6 millimoles per liter after 10 days from the start of insulin titration. More than the convergence time, safety of the dose guidance is of primary importance where we want to avoid any hypoglycemic events. And we can see for this population of 50 virtual patients, no severe hypoglycemic events occurred using our proposed algorithm. To summarize, in this talk, we considered the insulin titration problem and we proposed a model-free insulin titration algorithm which is based on a recursive least squares based extremum seeking control. This work is a first step towards model-free algorithm for insulin titration in type 2 diabetes as well as for data-driven closed-loop glycemic regulation. The proposed approach is not just restricted to type 2 diabetes but may also be used for model-free basal insulin titration for patients in type 1 diabetes. With that, I would like to conclude this talk and I would like to thank you for your attention.